Presence of hypertension makes a qualitative difference for the management of diabetic patients. And especially if it is resistant hypertension, the complication rates are very high. To discuss this topic, we have Dr. Prathosh Gangadhar from Kozhikode, Kerala. Over, Dr. Prathosh.
Thank you, Chairperson. At the outset, I'd like to thank Dr. Ganesh and Endodive MANGALORE team for the invitation. And I will be discussing approach to resistant hypertension. I was asked to focus mainly on approach to resistant hypertension, although it's a diabetes session. So if you look at the resistant hypertension definition, it's evolved over different guidelines from 2003, 2008, NICE guideline 2011. And if you look at the last guideline, it will be and European Society of Hypertension Guideline 2023. All these guidelines, although this evolves over the period, mainly says that if the patient blood pressure is not controlled with 3 antihypertensives, then you have to consider, provided you ensure adequacy of treatment, patient received maximum tolerated therapeutic dose, and they are not controlled, then you can consider it. So what is the best definition? You have one guideline. This is the guideline probably I am focusing more on resistant hypertension itself. It's a detection, evaluation management, AHA guidelines. It defines resistant hypertension as hypertension above goal more than 140/90 with concurrent use of 3 antihypertensives, which include calcium channel blocker, angiotensin converting enzyme inhibitor, or ARB plus diuretic. And all agents, as I already mentioned, should be administered at maximum tolerated doses at appropriate dosing frequency, or there is a second set to diagnose that controlled blood pressure requiring more than or equal to 4 drugs. So these are the 2 recommendations or definition to say that your patient has resistant hypertension. Now, coming to the prevalence, resistant hypertension is actually prevalent, quite prevalent. You can see that 9 to 18% on different studies. So on an average, you can expect 10 to 20% patient has resistant hypertension. So what are the patient characteristics you will look for? Generally, they will have multiple comorbidities. You can see obesity is an important factor. Diabetes is an important factor. Diabetes, why it causes resistant hypertension? Multiple reasons. Insulin resistance can lead to endothelial dysfunction, increase the vascular resistance. They can have autonomic dysfunction and sympathetic tone-related issues. And coexisting peripheral artery disease also contribute to that. And obstructive sleep apnea and primary aldosteronisms are more prevalent in diabetes. So there are different reasons to say that diabetes people can have. Most important will be diabetic nephropathy and early diabetic nephropathy and other related factors. Now, albuminuria, left ventricular hypertrophy, hypertensive retinopathy are important target organ markers, and these are important measures to see in clinics to see that your patient has probably resistant hypertension. And now, obstructive sleep apnea is an important cause for resistant hypertension. One should evaluate for obstructive sleep apnea in most of the patients who are having resistant hypertension. Now, coming to the prognosis, you can see that 32% increased risk of developing end-stage renal disease. That's the one issue with resistant hypertension. 24% increased risk of ischemic heart disease, and 46% increased risk of heart failure. And there is prospective studies using ABPM, there is ambulatory blood pressure monitoring, suggested an almost 2-fold increase in CVD risk. So stroke risk is also increased, ischemic heart events are increased, heart failure is increased. So before labeling a patient resistant hypertension, one should actually define and rule out pseudo-resistant hypertension. So what is pseudo-resistant hypertension? One is poor adherence to the prescribed drugs. So that is pseudo-resistance. White coat effect, I will explain that. And poor office blood pressure measurement techniques and clinician inertia. So these are the 4 important factors you will look into to diagnose pseudo-resistant hypertension. So are these entities are common? They are very prevalent. You can see that all these factors are around 30 to 70% prevalent in practice. So before jumping into resistant hypertension is due to some disease, secondary cause of hypertension, always look for these issues. So what are the important factors that affect adherence? Adherence is defined as remaining attached to a hypertensive medication regime. So you can see that in the first year itself, 50% of the patients are poorly adherent to the medications. And in even RCTs, clinical trials, 1 out of 5 patients have sufficiently high adherence. And generally, non-adherence is very high, to the tune of 7 to 60%. And there are multiple factors, patient-related factors like comorbidities, resource constraint, expensive medications, suboptimal awareness regarding hypertension-related issues, and lack of communication. These are the important factors for patient-level barriers to adherence. And clinician-level, many clinicians, when there is a complex drug regime prescription, there is also ineffective communication with the patient often leads to adherence issues from the clinician level. And again, multiple care specialists, patient is seen by many specialists, they are prescribing multiple drugs that can affect the adherence. That's a clinician-related factor, and clinician-related inertias are important. Now, what are the important strategies for improving adherence to antihypertensive medication? Go for long-acting medications, once daily preparations. FDCs, just like diabetes management, FDC has good role in hypertension management. Then low-cost generic versions. This is a recommendation from US, but in India, probably the quality of generic medications are a bit skeptical. We should realize that generic medications are one cause for resistant hypertension in our practice. So we had to take this recommendation with a pinch of salt and also educate the patient regarding the issues. So coming to white coat effect is an important entity where patient will have increased blood pressure when they visit the doctor. In office, blood pressure will be high, but when they are measuring blood pressure from home, it will be normal in a hypertensive patient who are on medication. It is not white coat hypertension. If the patient has hypertension, we will call it as white coat effect. If the patient is newly diagnosed and you are seeing a high BP from office, but home BP is a normal, we will call it as white coat hypertension. So white coat effect is different from white coat hypertension, and you can easily identify this by home blood pressure monitoring. And if you have availability of ambulatory blood pressure monitoring, you can do that. Now, detection of white coat hypertension, I already mentioned, patient will have a high BP in the office, but they will have normal BP in the home. And you should understand there is one more entity that is very important. This entity is called masked uncontrolled hypertension. So you have different permutation combination of in-office blood pressure and out-of-office or home blood pressure monitoring. If home blood pressure monitoring is high and hospital measurement is normal, we will call it as masked uncontrolled hypertension. How will you look and how will you diagnose that? This is very relevant because if your hypertensive patient has normal BP in office, you will not increase the antihypertensive dose. But if the patient has high CV risk, or if they have features of endogen damage of hypertension despite your treatment, you suspect this and order for home blood pressure monitoring, or you can do an ABPM. If you find high blood pressure in home, that is called masked uncontrolled hypertension. That is very relevant, and you can, once you are diagnosed this, you have to treat this aggressively. Now, proper blood pressure measurement, there are multiple techniques related issues, and we should be very careful. I am not elaborating this. You can take it just a snap. This is very well described in many of the publications. So importantly, I will say a few things. Even crossing your legs can increase during BP measurement by 3 to 50 millimeter of mercury. And just arm hanging freely, the other arm is hanging freely, can increase blood pressure by 5 to 20 millimeter of mercury. So there are even milder things that during blood pressure measurement can affect blood pressure values. So you should be very careful with proper blood pressure measuring technique. So clinical inertia is very common with the drug therapies. You can see that 50% of the patients in the US has improper dose titration. Doctors are not properly titrating to the tolerated dose so that they are not getting control. So this is an important factor. So once you exclude all these things, you will say that patient has probably resistant hypertension. And another important aspect will be drugs. So there are many drugs like NSAID, oral contraceptives, sympathomimetics like cocaine, amphetamines, immunosuppressants like cyclosporin and tacrolimus. In renal patients, you will use erythropoietin, and diabetic retinopathy patient will be on VEGF inhibitors. All this can increase hypertension. Antidepressants like venlafaxine And many antidepressants, MAO inhibitors can increase blood pressure. Even steroids and mineralocorticoid drugs can increase blood pressure. One important point is even simple antibiotics like linezolid, which has got a monoamine oxidase A and B mild inhibition. I have seen many patients developing accelerated hypertension and heart failure with preserved ejection post-op when they are using linezolid. So this is probably one thing you should observe with the drugs. Now, once you diagnose and excluded all these things and confirm the true resistant hypertension, then what to do? So the diagnosis I already mentioned, we need to exclude the medication adherence and a white coat effect. Now, always rule out secondary hypertension causes. Commonly, you will see primary aldosteronism, which is one of the most common cause of resistant hypertension and which is an endocrine cause. Then pheochromocytoma, Cushing syndrome. I will briefly go through some case scenarios. And renal parenchymal disease, again, you can easily diagnose with GFR monitoring, creatinine, and urine protein estimation. And renal artery stenosis, especially patient has recurrent flash pulmonary edema or renal brouillon examination, peripheral artery disease coexisting, asymmetric kidney zone imaging, you suspect renal artery stenosis in accelerated hypertension case. And obstructive sleep apnea, you should look. And if there is asymmetrical pulses, you can look for coarctation. Always look for the target organ damage. Look at the fundus of the patient for hypertensive retinopathy. Cardiac evaluation for LVH, you can diagnose by ECG or echo. Renal albuminuria and proteinuria and GFR you should measure. And peripheral artery disease, you look clinically and you can go for ABA index. So these are the measurement that is needed. Now, importantly, you can see that this is an interesting case of a young lady, 40-year-old lady with hypertension and hypokalemia. You can see that she had a large adrenal mass that is imaging suggestive of adrenal adenoma, but you can see that her aldosterone levels are very high. There is renin activity suppressed, aldosterone-renin ratio is consistent with primary aldosteronism, and she has metabolic alkalosis. She was operated and she had complete cure of all these things. So, but important myth you should remember, many PA patients will present with hypokalemia. That is not correct. It's very common cause. Many of the resistant hypertension, 5 to 10% of the cases, you will encounter primary aldosteronism and resistant hypertension, but only minority, 9 to 37% will have hypokalemia. So normokalemic hypertension is the most important presentation of PA. One should remember that. Now, you should need to screen PA. This is the large data from US, 1 lakh patients, more than 1 lakh patients, 3.7% cases of resistant hypertension. Only 2.1% were screened for primary aldosteronism. So even in US, the screening is much less. So we need to be very careful regarding screening for primary aldosteronism. It can be measured with a simple ratio, aldosterone-renin ratio, but there are different methods and you should know some points regarding measurement, especially plasma renin activity and direct renin concentration, two methods by which you are measuring renin. But plasma aldosterone concentration is freely available and it's done by ECLIA. But these two assays, you should be careful in the sense that DRC is very popular. People are doing it because it's easy to do, but PRA is a bit difficult for the lab to process. So one important point, this is a publication from my end. So you can see that if you're sending DRC and the sample is frozen and sent, you will get a high renin level. So you have to be cautious with that. And if you're sending PRA and you're sending the sample at room temperature, you will get a very low renin activity. So if you are not properly handling the sample and you are sending, mostly these tests are sent to a referral center, referral lab. So if you're not cautious with the sample handling, you could get a wrong result. So always look into this aspect. This is a second case, 71-year-old lady. She presented with accelerated hypertension and posterior reversible encephalopathy, and she had resistant hypertension, refractory hypokalemia. And evaluation showed a hypertension with metabolic alkalosis, hypokalemia, but her aldosterone renin were low. And you can see that there's an interesting case for her. She was taking indigenous medication. She was on multiple aristums, and she was taking 8 bottles for last 2 months. And why it's important? Because this ariston contain an entity called Glycyrrhiza glabra, that is licorice. Licorice is a common content of Ayurvedic medications. You can see that this molecule actually inhibits 11-beta-HSD2 enzyme, which converts cortisol to cortisone. And what happens is this excess cortisol acts on mineralocorticoid receptor that can lead to an acquired apparent mineralocorticoid excess state that will lead to hypertension, hypokalemia, and accelerated hypertension. So just stopping that medication with addition of spironolactone actually cured her disease and she was discharged with these agents. So just diagnosing these things, even herbal medicine can lead to persistent hypertension. This is one important take-home message. This is a classical scenario. You can see classical Cushingoid striae with a mediastinal mass, and this is a classical presentation of ectopic acid secreting Cushing syndrome, where patient present with resistant hypertension, hypokalemia, metabolic alkalosis, and Cushingoid stigmata. He has a thymic carcinoid. He has operated, and she had cure of resistant hypertension. So risk factors evaluation, you should look at ABCD. Adherence is one thing. Biology, where older age and the diet, high sodium intake, and obesity and smoking. Diseases, chronic diseases like aldosteronism, diabetes, sleep apnea, and drugs, many drugs we discussed. All this you can look into to evaluate patients with resistant hypertension. How will you manage? Generally, the diet, important aspect is low salt diet. You just don't tell low salt. Ask the patient to take less than 2 grams sodium. How they can take that? Less than 5 grams of table salt per day. So that's the advice you should give. And along with that, you advise the DASH diet. DASH diet means increase vegetable, fruits, and low-fat dairy products, along with the low salt and exercise, and 6 hours of interrupted sleep. And once you manage resistant hypertension and you start with the 3 medications and not getting control, then first step is to you can optimally substitute thiazide diuretic. Whatever diuretic you are using, change to chlorthalidone or indapamide. That's the first change you should do. Still, you are not getting adequate control of blood pressure. Step 3 should be seen. Step 3 is adding a mineralocorticoid receptor antagonist like spironolactone. If the patient is not tolerating spironolactone due to painful gynecomastia or hypogonadism symptoms in male, you can switch over to eplerenone. Still BP not on target, you can go to step 4. Step 4, you can look at the pulse rate. If pulse rate is more than 70, you can add beta blocker, either metoprolol or bisoprolol, or you can use an alpha beta blocker like labetalol or carvedilol. And if it is contraindicated, beta blocker any contraindication, you can add clonidine. So other option is diltiazem. Next step is still not controlled, then the 5th option is hydralazine. You can add 25 milligram thrice daily. And if the patient has heart failure or reduced ejection fraction, you can use the combination of isosapate mononitrate, which is available in India with hydralazine, and which can be added for control of refractory hypertension. Step 6, still not getting control. Minoxidil is an option, which is a reserve drug, not commonly available. And you can also refer a patient for procedure like renal denervation that has got some role, but it should be carefully selected, your patient for that procedures. Now, finally, what are the important treatment modifications you should consider? If the patient has increased edema, difficult to get volume control, you can add thiazide, chlorthalidone could be added. If it is not getting control, you can increase loop diuretic, but usually you need to use twice daily loop diuretics. Then heart rate inadequate, you can consider whatever agent we discussed, but other options are if there is contraindication, you can consider verapamil or diltiazem. If renin and aldosterone levels are low, low salt diet and amyloid could be effective. And renin low, aldosterone normal or high, just like primary aldosterone, imaging negative, you can use spironolactone, eplerenone. If the blood pressure is not getting control with the current schedule, always look whether you can split the dose. And you can do ambulatory blood pressure monitoring to decide that. Then if there is medication adherence in question, always directly or indirectly ask the patient, discuss frankly, but don't do judgmental statements, and you can discuss and solve that issue. And if there is any BP related fluctuation you expect outside clinician visit, you can do ABPM or whole blood pressure monitoring to see the effect of meal and duration of medication effect. Now, always look for obstructive sleep apnea and stress and panic disorder related fluctuation where you need other medication. Now, this is the summary of whatever I told. This is the last slide. BP control is more important than drugs. So this is one of my patients who has primary aldosteronism, and this patient was not tolerating spironolactone. You can see that patient presented with grade 4 hypertensive retinopathy papilledema. You can see initial fundus images. Although she was not tolerating spironolactone, you can see that with good blood pressure control, her eyes were improved, and you can see her fundus normalized. So this you can observe this target organ, retina, with your treatment, and you can educate the patient regarding the benefits. So this is a way to improve the blood pressure control, and you can do that with proper individualized management of the patient. Thank you.
Thank you, sir. The dais is now open for discussion.
One of the most common setting where the blood pressure becomes a real terrible task to control is CKD, in spite of multiple group of drugs. What do you do in such situations?
Yeah, again, the algorithms hold true here, but in CKD, one thing you should careful regarding is thiazide diuretics may not be effective with worsening of GFR when it crosses more than 30. Only metolazone works. That's the only thiazide diuretic probably works there. And aldactone is a bit risky. ARBs are a bit risky, although you have to be cautious. ARB has, especially in diabetic nephropathy, ARB has got definite advantage, but hyperkalemia and some patient, especially if they have coexisting renal artery disease, they can have a fall in GFR with use of ARB. So you have to be very cautious with use of spironolactone here. Generally, the third line drugs like clonidine and beta blockers, alpha blockade, these drugs could be useful at that setting. And you have to use multiple drugs, and generally hypertension is refractory. Even in CKD, you need to exclude secondary causes. We have seen patients with primary aldosteronism being missed in advanced grades of CKD, where you may not offer much in such patients. And even there are some genetic causes you could encounter in CKD. So probably some genetic evaluation will give you some clue regarding which drug to choose, and that could be good in that setting. Thank you. Thank you, sir.
Is Reserpine available now, because it was earlier a very popular drug even for resistant hypertension? Reserpine.
Yeah, Reserpine is still available. I have looked for one patient who had refractory hypertension. It's as a combination, Adalfin acid. It's still available in market. In some patient, it could be useful in refractory hypertension.
And how many of these patients where there is resistant hypertension remit and are able to control with just a couple of antihypertensive medication? How many of these resistant hypertensives remit from this resistant state and we are able to manage with a couple of drugs after some time? And is there
definitely.
data?
If you are diagnosing endocrine causes like primary hyperaldosteronism, if you add spironolactone, they will have dramatic response. I have seen patients who are on multiple drugs, 4-6 drugs. The drug burden reduced to 2 or 3 drugs after initiating treatment. So it's always good to look for secondary causes. That is very common, like primary aldosteronism. Another point probably I didn't include, we recently did a study with ambulatory blood pressure monitoring. We have 1 hour ABPM in OPD just to diagnose white coat hypertension as a simple tool in comparison to 24-hour ABPM. We found that just doing 1 hour ABPM with 12 measurement over 1 hour, every 5 minutes, you can at least diagnose with a remarkable sensitivity, not to the 100% sensitivity, 80% of the cases you can diagnose white coat hypertension just doing a 1 hour ABPM in office. So you can avoid a long 24-hour ABPM. That may not be practical.